So what I'm going to do is very similar to what Rajiv has done. We're going to have some time to iterate and discuss and brainstorm updates to the guideline. What I wanted to do was just provide a bit of color and a bit of maybe just some complexion to some of the developments in the area. Part of this is just a bit of a refresher, a bit of a reminder, and maybe just to amplify a couple of points that I think deserve some extra amplification since our last update. I think that it's clear, much like schizophrenia, Rajiv covered this very nicely. I don't think bipolar is any different in the sense that we have a very long list of therapeutic objectives. And I think that the guiding principles that we have in our guidelines currently, our last iteration would stay as is. I think when we're talking about bipolar disorder, quintessentially multidimensional, and we're talking about treating acute mania, we're talking about acute bipolar depression, and we're also talking about maintenance. And I don't think anyone can have a conversation about bipolar disorder with also a attention paid to aspects of the interepisodic period where persons are often very impaired, they're with debilitating problems with sleep, comorbidity, cognitive problems, trait level affective disturbance, interpersonal consequence as a result, and of course the issue of suicidality, which is always an issue in all of our patients, but certainly in bipolar disorder throughout. I just wanted to start off with pediatrics. Now, we're not focusing on pediatrics. There's not any new treatment suggestion in pediatrics. This was just a study looking at trauma. It's interesting because the age of onset of bipolarity in North America, the modal is estimated about 18 to 20. In Europe, it's about 10 years later, which is interesting. And there are evidence to suggest this might be a result of the higher rate of trauma, self-reported trauma in North American populations. Trauma is a frequent occurrence in childhood in people who are adults living with bipolarity, and the trauma is highly associated with a younger age at onset or declaration of bipolarity and a much more severe, much more complicated illness presentation. But I just think I brought it in just as a reminder that we're going to be focusing on much of the foundation of treating bipolarity is pharmacotherapy. It has certainly been clinical experience and certainly lots of evidence now to support that the great majority of people are going to require a psychosocial intervention added to the pharmacotherapy, in some cases because of aspects of stressors in childhood and trauma, but a whole variety of other aspects that could be targets. So this is really just my reminder of the social economic determinants of health in bipolarity, but also a reminder of the need for having psychosocial treatments, and we'll have more to say about that in a moment. During previous meetings we've had over the years, we've talked a lot about comorbidity. Just to embroider a little bit of percentages and numbers on this conversation, more than 90% of people who live with bipolarity meet the criteria for one or more other mental or, in quotes, medical disorder. I appreciate that typology is stale dated. Medical and mental are really the same thing, but more than 90% and more than 50% meet the criteria for three or more conditions. Relevant to psychotropic drug selection, among other considerations, is weight, BMI, abdominal adiposity, glucose dysregulation, and not to bombard with too many percentages, but 20% of people living with bipolarity meet the American Diabetes Association criteria for type 2 diabetes. An additional 30% are pre-diabetic. So 50% of this population is living as pre-diabetic and or declared as diabetic. This is a more recent update we've done in the field, just going back to this literature. Not only is the rate of diabetes increased, but so is obesity, abdominal obesity, metabolic syndrome, and a topic that we don't spend as much time talking about in psychiatry, that being NAFLD, non-alcoholic fatty liver disease, which is also apparently elevated in bipolarity and in schizophrenia. So we're talking about a population that has this comorbidity. Now, with respect to our guidelines, we guidelines assumes the patient's been diagnosed and they've been diagnosed accurately. It's still the case across the country that this is a major problem, that is to arrive at a diagnosis timely, accurate. And it's still the case that we're looking at least a half a dozen years for a person living with bipolar 1 disorder, maybe twice that much in someone with bipolar 2 disorder, to be diagnosed, despite the fact that they are, in quotes, high utilizers of healthcare services, primary care and specialty care. And I think this has been something we've all recognized as clinicians. We're familiar with this deficiency. And it's interesting because I was part of a survey. It's going to be published very, very soon. It may already be published. We asked clinicians across the US, are they familiar with screening tools for bipolarity? And there was a unanimous yes, in fact, almost 80 to 90%. And many could just spontaneously cite a screening tool. And then when asked about implementation, the great majority said, no, we don't use them. And there has been a bit of pushback on screening tools in the sense that some people have taken the view that there's a pandemic, if I can use that, of false positives with screening tools. And so they've kind of thrown the baby out with the bathwater. Just a refresher that PHQ-9 goes back to the year 2000. It kind of languished along a little bit as a implementation measure until CMS got behind it and a few other organizations got behind it, and there was quality measures associated with it. And so just wanted to let our group know that there's been a new screening tool for bipolar. We validated, my colleagues, my team across the US. And the effort was not to repeat what we already know, but to find a screening tool that is improved in psychometrics. And the inter-observer agreement for schizophrenia is considerably higher than many populations with bipolar disorder. And this is continuing to be a major problem for us. So I mean, we have this in our guiding principles, but at the end of the day, the diagnosis is a clinical diagnosis. The screening tool, of course, doesn't diagnose bipolarity. And it does require a very deep in vivo characterization of the patient. So I think we just want to I think we have some language around that in our guidelines. This is certainly continued. Of course, biomarkers, biosignatures are exciting for the future. I met with a team in France about 6 months ago, Maria, a place you know well, in Paris, and they have, in quotes, a blood test for bipolar disorder. And I think that that's very exciting and very headline grabbing. I don't think it's quite made it across the finish line yet, but this is where the field's going. But in the interim, we've got to get this diagnosis. And that diagnosis still remains a probabilistic diagnosis. And I'm really quite struck that when I travel across the country and around the world, I keep hearing from colleagues who really swear by the use of a test, a neuropsychology test or an imaging test, radiology, and make the diagnosis of bipolarity. It continues to be a clinical diagnosis, and a diagnosis that is challenging in the best of times, and especially challenging with a brief office consultation, especially an observation which is not really, I think, fully quantified or characterized, but there's certainly an impression amongst experts in this field globally, not just in high-income countries, but middle and low-income countries, that the phenomenology of bipolar disorder may not be what it used to be. Insofar as, I remember when I started in the business, we used to refer to atypical presentations of bipolarity was the mixed dysphoric. And the more typical presentation was the elated and grandiose, very stable episodic patient. Well, it's kind of flipped the other way around now, insofar as we see much more patients who are living with bipolarity, who are more dysphoric and irritable and anxious and agitated. And a number of years ago, I started this campaign trying to teach clinicians around the world about what I called the 4 A's, not a boiler in schizophrenia, but the 4 A's of bipolar disorder: anxiety, agitation, anger, and attention. The details are really more of peripheral relevance to our meeting here today. But I think that to really get into the granularity of bipolarity, suggestions for treatment, without at least a mention about the need for routine, systematic screening for bipolarity and repeat screening for bipolarity. If the initial screen and careful assessment proves not to be hypomanic or manic, we still need to revisit that, especially in TRD presentations. And I think what's been especially confusing to clinicians is the reality. I suppose we can blame Mother Nature on this, and that is that mixed features are not only part of bipolar 1, bipolar 2 depression, but are certainly part of MDD. And that line, which is an imperceptible line that would disambiguate MDD from bipolar spectrum, is a tough line for many clinicians to find. But we recognize that. So we have clearly complexities around detection, diagnosis, comorbidity. Let's now, if we can, focus down. Subsequent to our previous meeting, our last guideline we created, I published this paper in Lancet to really summarize as pithy as I could the drop-down menus as it relates to new treatments, either FDA approved and or proven to be effective in bipolar disorder across different phases of the illness. And I've highlighted in the red a relatively new entry. This is olanzapine samidorphan. This is a medication that is approved for schizophrenia, but also approved for adults living with bipolar mania or mixed as monotherapy or adjunct to lithium valproate, as well as a maintenance treatment. And Lybalvi, as it's known commercially, was approved in June of 2021. There were no studies done in bipolar disorder with this new chemical entity. This medicine was grandfathered. FDA allowed the company to have an indication with the assumption, which I think is a very fair assumption, that olanzapine's efficacy in mania in maintenance has already been established. So the company was behooved to do studies with this entity in schizophrenia to demonstrate its efficacy, its safety, and its weight mitigation effect. So it's a relatively new entry for us to the field. Just one point I wanted to bring up, or a point I don't want to forget to make. This was a paper that caught my eye. Ron Kessler, I think everyone would know Ron out of Boston. He was the first author on this paper last June. And this was data that was obtained by the World Health Organization. And for me, it really is the call to action. This was an effort to look at people who have either major depressive disorder or bipolar disorder, mania or depression. I've purposely put a red rectangle around where I want people to look. And what you're looking at is the percentage of people, in this case, bipolar, but it's also major depression, who move on to the next step. So, to colleagues around the table and all my colleagues joining virtually, we're going through first, second, third, fourth line. And this was a estimate of the percentage of people who go on to the next step beyond first line. So in bipolar disorder, only about, I'm going to round it off, between 4.2 and 6.4, only 5% of people with bipolar disorder, if given a first line treatment for bipolar mania or depression, only about 5% go on to the next step strategy. 95% just flounder along on the index strategy. Major depression ain't a whole lot better at 25%. So I think that, again, a reference could be maybe in our guidelines that despite the fact we encourage next step, and this was not just, this was a global study, that the great majority of patients are just floundering along. And I think busy clinicians have seen this frequently in their practice. Again, samidorphan combined with olanzapine has now the approval in schizophrenia. It's a new entry. It was not studied in mania, mixed, or maintenance, but got the indication. I think everyone knows this medicine. It's a proprietary formulation where samidorphan, which is largely a mu-opioid antagonist, is mitigating the weight of olanzapine, the overall change in weight, change in BMI, and waist circumference. And olanzapine in schizophrenia, of course, we know it. It's highly efficacious. We know it's amongst all the oral non-clozapine antipsychotics, it certainly is recognized as an effective treatment, but burdened by weight and diabetes and so on. Its recognition as an effective anti-manic in mood stabilizer in bipolarity is also well documented, and people know this drug well in the space. But just like in schizophrenia, it loses a lot of marks because of the weight, the diabetes, the dyslipidemia, and as such has largely been taken off most people's consideration. Now, we can debate whether the mitigation of weight is just more statistical significance and not clinically relevant. That's a longer conversation. But I would say, look, I think that we can debate whether glasses are half empty, glass full. But for some people, whatever that percentages is or how to quantify that's to be determined, the level of weight mitigation may be enough for them to make this an acceptable treatment. And it's not as though we have a fully satisfied group of people living with bipolarity. So I think we need more options, and this is something that's been new. Now, what's also new for us for this version of our Florida guidelines is lumateperone. So Caplyta lumateperone was approved in December of 2019. For people living with schizophrenia, and of course that's been reviewed already. I just wanted to speak to the topic of bipolar disorder. And this is a slide that breaks down the current 5 FDA-approved agents for bipolar depression. And frankly, if I was going to show one slide today, it might be my one slide. I think this kind of captures it very neatly and very clearly, that in monotherapy in bipolar 1 disorder, in depression, this is bipolar depression, we have 5 options. In bipolar 2 disorder, depression, we only have 2 FDA-approved agents, that being lumateperone, quetiapine, and the quetiapine indication was as a monotherapy. We have Caplyta now indicated in bipolar 1, bipolar 2 in monotherapy and as adjunct. So that's something new. And one of the questions that then I think comes up is that we certainly don't have enough data to create a new bipolar 2 depression algorithm with 2 options. We don't have enough to work with there. But I do think it's interesting because there's been a study, many may have seen the press release 3 weeks ago, where for the first time ever in my time in this business, a very large study was done, which might even be labeled a pivotal trial, that included major depressive disorder and bipolar disorder in the same study. And that was in mixed depression, and that was with lumateperone as well. So that's just more for your interest. So we have not just Lybalvi as a relatively new entry, but now we have lumateperone in bipolar depression. One other new entry I wanted to mention, and this is, again, more for your interest. This may not be relevant to how we craft what we're going to do today. This is dexmedetomidine. Dexmedetomidine is a drug circa 1999. Just to back up, back in 1966 is when clonidine appeared on the pharmacologic landscape. And we all know that's a presynaptic alpha-2 adrenal receptor agonist. And similarly, dexmedetomidine is also a presynaptic alpha-2 adrenal receptor agonist, and it's been used in anesthesia for years and also pain management, but was approved by FDA for the treatment of agitation in adults living with schizophrenia, as well as the treatment of agitation in the adult living with bipolar 1 or bipolar 2 disorder. So this is a relatively new entry to the field, that being how to manage agitation in the emergency room setting. Just to get a bit of color on bipolarity, we aim always for monotherapy. That's a noble objective. Mother Nature often has a difference of opinion, and monotherapy becomes really a myth, frankly, for most people who live with bipolar. There are many studies now that have been published that not only have provided an estimate of polypharmacy in bipolarity, but there are other studies that might give one reason to believe that amongst all considerations in the DSM-5 text revision, bipolar disorder might have the most polypharmacy of all. Not a bragging right anyone particularly wants, but anyways, but polypharmacy is certainly very, very common. And we have now FDA approvals for combination strategies in bipolar mania, adding, for example, a second generation antipsychotic to either lithium or valproate. There's combination strategies in bipolar depression, lumateperone added to lithium or valproate. But of course, we're always aiming for monotherapy. I thought you'd find this interesting. This appeared just a couple of years ago. Greg Rhee, Marie Greg is someone you've met before. This is a epidemiologic study that appeared that's been highly cited, as it should be. It was well done. And it's really, I think, why we're gathering here today. And that is the implementation gap, what we know versus what we do. And this looked at the type of psychotropic drugs prescribed across America in adults living with bipolarity as a function of epoch. So going back over a period of 20 years, from 1996 to 2016, what has occurred is a significant decrease in the use of lithium. In fact, I would say quite concerning decrease in the use of lithium. Secondly, there's also been contemporaneously a significant decrease in the use of valproate in bipolarity. That one I have less concerns about. Many would know that in France and in the UK, there's been Dear Healthcare Professional letters that have effectively said cease and desist using the medication. A good friend of the Florida Guidelines, Marlene Freeman, editor-in-chief of J-Clin Psychiatry, came out recently in an editorial. She was saying we should not use valproate at all, reproductive age women. Again, very strong statements. Others would be sharing the valence of that, but may not be so categorical, and may say, well, there's still room for valproate in bipolar in reproductive women, but caution, of course, and concerns are many. But to shift to antidepressants, and this is the part I thought you'd find interesting, where the line is just skyrocketing is the use of antidepressants in bipolarity. And we know that antidepressants, the conventional antidepressants, are not FDA approved, but are prescribed frequently and on the up and up. And what's really interesting is that when Greg looked at antidepressant monotherapy in bipolar disorder, that's been skyrocketing. And most would know that if you sat your board exams and the examiner said, what's your view on antidepressant monotherapy, you better say you don't support it. Because that's not what we're supposed to be doing. Now, I would say that the truth is that, well, what is the truth? Certainly in bipolar 1 depression, I think there's a consensus that antidepressant monotherapy is not the way to go. There are data in bipolar 2 depression wherein antidepressant monotherapy could be safe and effective. But taken together, this is something quite discordant with what we try to recommend. Antidepressants in bipolar depression, obviously they're linked to treatment emergent switch or treatment emergent mania. That doesn't happen very often. Experienced clinicians know that doesn't happen very often. That can happen, of course. The number needed to harm with respect to treatment emergent switching is around 150 to 200. That's not a common event. What's more common is nothing happens. Antidepressants just don't work, and nothing is delivered with respect to desired outcome. There's a colleague in Kentucky, in Louisville, Rif El-Malak. He coined this acronym called ACID, antidepressant chronic induced dysphoria in bipolarity. I think he's really right on that. I love that acronym because it is like acid in not, I don't mean like LSD, but I mean pouring acid, something toxic, onto the bipolar patient. A lot of these patients get quite irritable and get sort of sub-threshold affective lability that's often missed and is determined to be part of the illness, which it could be, but a non-mutually exclusive formulation, it could be iatrogenic artifact. And so that's a more common situation in bipolar disorder. Now, we talked a little bit at our last meeting when we were updating guidelines. Ketamine was certainly very much in its infancy in bipolarity. I'd like to say it's moved through adolescence to adulthood. I can't say that. We just recently published a guideline in the American Journal on how to use ketamine in depression. And what our group concluded was there was room for this medication in bipolar depression that's treatment resistant, often persistent, often severe, and also room to consider ketamine or S-ketamine in adults with depression and suicidality, but bipolarity. But then there's a but, and the but is we just don't have large RCTs randomized controlled trials that are multi-dose and certainly nothing that's long-term. Those studies are underway. We're doing some here in Toronto, but ketamine has been an important treatment. It would still be in the area of investigational, be off-label. Spravato is approved in major depression, not bipolar depression, but it also is being studied in bipolar depression. So consensus in the field that there is a role for ketamine and S-ketamine off-label, but it would not yet have satisfied level 1 criteria, that is level 1 evidence in bipolarity. This was a study out of France. I'll draw your attention to the pink and the green, or whatever, I don't know my colors, that looks pinkish or greenish to me. This was an effort to look at the reduction in suicidality with IV infusion of ketamine in the very acute presentation of the patient. And 2 points. One is we saw an anti-suicide effect in bipolar disorder, and we saw it rapidly, and that anti-suicide effect was even more pronounced than seen in major depressive disorder. And we don't have quantified outcomes of this yet. We're looking at this, but this would in many ways accord with my own impression. We've had over 7,000 treatments now of ketamine, of which a third of them are bipolar, and we are seeing this effect as well. And just for everyone's aware, again, this is just more providing a bit of color where the field is. There's a lot of interest in using these newer innovative approaches, not just to improve depression. Obviously, that's an important target. So is suicidality, but also so-called domain-based outcomes, which is, I think, one of the areas that people are thinking more about, developing treatments for targeting domains. This is an Israeli organization that is really interesting. They're in bipolar depression, combining the approach of giving a patient IV ketamine for one infusion and then transitioning them to this combination of lorazepam, which has D-cycloserine mixed into it. And Rajiv had spoken to the glycine modulation in schizophrenia, and that is also occurring in bipolar. This is investigational, more for your interest. ECT still remains underutilized, highly effective in the short term. There's fewer studies in the long term in bipolar depression. And also in more treatment-resistant mixed presentations. This is an interesting study. Again, this is more for your interest, but just to illustrate not just innovation, but also the critical role that metabolism is playing in bipolarity. This was a clever study where a colleague who's not too far from me in Halifax, Canada, took a group of people with bipolar depression and treated them with metformin. 1 to 2 grams, up to 2 grams of metformin. And rather than just hypothesize it would work versus a placebo, the hypothesis was it would alleviate depression and bipolarity in persons who, during their time in the study, would convert from insulin resistance, as measured by a HOMA-IR, to being insulin sensitive. And that's what they discovered. In other words, as you move someone along to greater insulin sensitivity, their depression gets better. It's an interesting concept, but I think it's also a reminder of why we've got to be managing above and below the neck. A bit later on this afternoon, we're going to talk about major depression, Auvelity, which is dextromethorphan, bupropion. That's been approved now for adults living with depression. That approval came in August of 2022 last year. Just to let you know, again, just more for your interest, there's been a lot of interest with dextromethorphan in bipolar depression. Dextromethorphan, by the way, goes back circa 1940s. And this was a study in Asia combining memantine, which is also glutamatergic and uncompetitive NMDA antagonist, with dextromethorphan, which is also an uncompetitive NMDA antagonist. So kind of super duper hitting the NMDA receptor, improving bipolar depression. Now, not everything works. N-acetylcysteine is an antioxidant, a prodrug to cysteine. It was widely touted in bipolar disorder about 5 to 10 years ago, maybe 15 years ago. And more recent data, gravity kicks in. This is the Gardner hype cycle. I don't think we're at the zone of disillusionment, but there's actually been really a significant attenuation of our excitement for this approach. And I think in some defense of the antioxidant approach to bipolarity, like other types of inflammation approaches, metabolic approaches, it's going to come down to subphenotyping these patients to identify a subgroup more or less likely to benefit. Light therapy is still effective. Light therapy has been subjected to more reviews and systematic reviews. There hasn't been a lot of new data in the field, but it certainly is something we continue to use, not only in the seasonal bipolar depression and major depression, but also in non-seasonal depression. With respect to cognition, I was hoping that we would be here today and say, guess what? We've got a new pro-cognitive agent in bipolarity. We don't. Vortioxetine is the only one that we have in the MDD category of treatment options that are FDA approved, that are recognized as being pro-cognitive. We don't yet, and that's a serious problem. Just like schizophrenia, a large percentage, in fact, 2/3 approximately, people with bipolarity have age, sex, education matched evidence of deficits in one or more cognitive domains. And there's a long list of different ways that we're trying to look at this, and that's a conversation for another time. But I just wanted us to update the group saying this continues to be identified as a critical therapeutic target. There's a number of different treatments that are under investigation. People have begun to look at cognitive therapeutic approaches for this. And I would say that all of this is a work in progress. We don't have anything that I could say is evidence-based I would put in my algorithm. But some data, just like in schizophrenia, where cognitive remediation has been shown to improve not just cognition, but also the challenge with cognitive remediation is what's called FAR transfer. Can this transfer to everyday quality of life and day-to-day function in the real-world habitat? And there are suggestions this can also translate into improved psychosocial function. So I think that that's still a work in progress. So I think for me, I wanted to keep this very brief, is that as far as the new entries are concerned in bipolarity, we have lumateperone, we have the new entry, olanzapine, samidorphan, and in the case of lumateperone, its indications in bipolar 1, bipolar 2 depression, monoadjunct. And in the case of Lybalvi, olanzapine, samidorphan, that agent has attenuated weight. And we can maybe discuss more whether because we had previously put an asterisk next to olanzapine because of its weight gain liability. And that was to be considered in the treatment selection and sequencing. And we can maybe just socialize amongst the table here how we see olanzapine, samidorphan perhaps differently. So I got about a half a dozen new treatments we're going to discuss in major depression this afternoon. So we had a couple of new entries here in bipolar disorder.